when I'm ready.
Well, good morning, everyone. I think we'll go ahead and get started. Welcome to our first Grand Rounds lecture of the year. We're very fortunate to have Mark Rabbat from Loyola University in Chicago here this morning. Mark is going to talk about advanced imaging capabilities with CT, specifically not just seeing the blockage, but being able to assess the functional significance of the blockage with non-invasive imaging. Mark is Associate Professor of Medicine and Radiology at Loyola. He works at the VA Medical Center there, works with a former fellow of mine and a good friend. And Mark has published widely in this area, so we're really fortunate to have him here this morning with us and talk about something that we really don't know a whole lot about. So thanks for coming. We appreciate you making the trip. Are you ready, Enoch, or do I need to stall for a little bit more? Anybody know a good joke? Just advance on this.
Well, yeah, but he wants the pointer. The pointer is here.
Sure.
So this one.
Okay.
Pointer, and
Let's go without that. So without further ado, welcome, Mark.
Thank you very much.
all right, you're set.
All right. So everyone can hear me? Thank you very much for that kind introduction, and thank you very much for having me. This is really beautiful, this landscape. It's actually my first time in Napa. It's too bad I didn't, I'm not gonna spend the whole weekend here. I'm actually flying out later today, but I'll definitely have to come back. I feel like I'm in a boy band with these like headsets on. I don't know. I'm not used to wearing these around my ears when I'm giving a talk, but I'll go ahead and get started. So I'll be discussing the new paradigm of coronary CT angiography and FFR by computed tomography for patients with suspected coronary artery disease. And here are my disclosures. So I'd like to begin by discussing the diagnosis of coronary artery disease. And this is a large healthcare burden. Cost of care expected to grow by greater than 75% to over $300 billion by 2030. Now, the standard pathway to diagnose coronary artery disease relies on, the bread and butter is non-invasive stress testing, okay, the majority of which is SPECT imaging in the United States. About 80% of our non-invasive functional stress tests are SPECT, followed by stress echo, exercise, ECG, and in select centers, stress MRI as well, mostly at academic institutions or large centers. Do you perform stress CMR here, regadenoson, or no? Okay. Yeah, so not many centers do, but that is an option for patients. Now, how good are we at diagnosing coronary artery disease? Well, in fact, in a study published in New England Journal of Medicine in 2010, nearly 400,000 patients from the American College of Cardiology and NCDR registry, you can see that 2/3 of diagnostic angiograms did not demonstrate obstructive coronary artery disease. And in fact, 28% of patients with a negative stress test actually had coronary artery disease. In a more contemporary analysis in JACC, 80% of patients with a positive non-invasive test had no obstructive coronary disease, and nearly half of patients with a negative non-invasive test had CAD. So what does this data tell us? Well, one, we're cathing far too many patients only to tell them they don't have evidence of obstructive coronary artery disease. And two, we need a better diagnostic pathway to identify these patients prior to sending them to the cath lab. So, and irrespective of the non-invasive stress test modality, whether it be SPECT, stress echo, exercise ECG, or CMR, greater than 50% of the patients who subsequently undergo ICA have no evidence of obstructive coronary artery disease. And this is data from 385,000 patients from over 1,000 US hospitals. So I'd like to go over this case. It's a 58-year-old male with no symptoms. He had multiple cardiac risk factors, family history of coronary artery disease, high blood pressure, elevated LDL. He was overweight, high stress job, poor diet. This fits bill for many of our patients. So he was started on a statin, but it was discontinued. He had a stress MPI, nuclear stress test, that was normal. Then went on to develop some chest pain at rest. He had a repeat nuclear stress MPI, which was negative. He continued to have ongoing symptoms and subsequently underwent cath and an urgent bypass surgery. Anyone know this patient's story? Anyone know who this patient is? Any guesses? Exactly. Nice. This was President Clinton. Yep. This was his story, and this is how he presented. And after his bypass, he actually underwent PCI. So a recent study from Duke University, published in JAMA Cardiology, 15,000 patients, found that patients with a positive stress test were actually the least likely to have obstructive coronary artery disease at the time of their cath. And in fact, those with a positive stress test were the least likely to get revascularized, even compared to those with negative stress tests. Now that brings us to coronary CT. CT is a superb non-invasive imaging modality to assess for stenosis in the epicardial coronary arteries. This is an example of what we call a three-dimensional volume rendered image of the whole heart. You can appreciate the exquisite detail, spatial resolution. This is really fantastic for identifying origins and courses of coronary arteries. I don't really use these 3D volume rendered images to assess stenosis, but it gives you a nice lay of the field of what to expect. Because they're three-dimensional acquisitions, you can rotate the images in multiple planes and orthogonal cuts. You can splay out the epicardial coronary arteries, such as this. This is an example of the right coronary artery, demonstrating no evidence of obstructive coronary artery disease. Here are a couple examples. Anyone want to take this case? What are we seeing here? Any takers? So there's a stenosis at the bifurcation of the circ-OM system right here. And you can appreciate that on the 3D volume rendered image here. And the patient underwent a cath demonstrating and corroborating that bifurcation lesion at the circ-OM system. Here's another example. There's a lesion right here. Anyone want to take this? So this is the LAD diag bifurcation right here. You can appreciate there's evidence of calcified and non-calcified plaque right here. The patient underwent an invasive coronary angiogram that corroborated the CT findings right here. And one more example, the arrow is pointing to a prox LAD lesion that's non-calcified, pretty severe in stenosis severity. And it was corroborated nicely on the invasive coronary angiogram. So how good are we at identifying obstructive coronary artery disease using CT? Well, the sensitivities and specificities are quite high, and this is irrespective of the hardware utilized. So in the early days, using 64 slice scanners, now we have dual source CT scanners, 320 row scanners. All the data would suggest that the sensitivities are in the 90+% with a high specificity, 90+%. And this is comparing anatomic stenosis to anatomic stenosis. So CT stenosis greater than 50% to a cath stenosis greater than 50%. Now, CTA alone is a pure anatomic assessment. Okay, we'll talk about the bridge of computational fluid dynamics to a static CT to simulate blood flow and pressure, calculating FFR later on in the talk. But if we're talking about CT alone, it's pure anatomy. So there's no hemodynamic information with a pure CT alone strategy. And it's purely diagnostic, so we can't intervene at the time of the acquisition, and it shouldn't really be done in patients who are toxic, hot-looking, positive biomarkers, dynamic EKG changes. Some patients need to go straight to the cath lab, right? So we're talking more intermediate risk patients, if you will. And the negative predictive value of CT is its real strong point, right? And what this translates into is a confidence in us as providers to tell our patients that they do not have evidence of obstructive coronary artery disease. If you do not see any atherosclerosis, any stenosis on a CT scan, we could confidently tell them that they don't have obstructive coronary artery disease. And that confidence also translates into a strong warranty period. And what I mean by that is patients aren't having events for at least 7, 8 years, and I suspect that to reach a decade after a negative coronary CT angiogram, which has great prognostic implications compared to bread and butter functional stress testing, where we tend to see an uptick in events after 18, 20 months after a negative functional stress test. So that's really important. This is another example of a 46-year-old female patient who had chest pain. The stress ECG was positive. You can see the ST depressions. Instead of going straight to cath, the patient underwent a coronary CTA, and her epicardial coronary arteries were completely normal, and we were able to spare her an invasive coronary angiogram. Now I'd like to switch gears and talk about some of the prognostication of coronary CTA. This was one of the earlier studies published in JACC in 2007 using 16-slice CTA. And what the investigators did was they divided up the coronary tree into 16 segments, and they divided up in each segment and assessed whether there was or was not plaque. So they didn't characterize the composition of the plaque or assess for adverse plaque characteristics, whether there was or was not plaque. And they found that greater than 5 segments had atherosclerosis, their overall survival was worse compared to those who had less than 5 segments involved. This is data from the CONFIRM registry of over 23,000 patients without known CAD who were followed for 2.3 years. The average age was 57, and there was a 62% intermediate pretest likelihood of coronary artery disease. And what they were able to demonstrate was that if you had obstructive coronary artery disease, your prognosis was worse. And your prognosis was worse with more vessels that were involved. So if you had 3 vessel obstructive coronary artery disease or left main, your prognosis was the worst of all. And I wanted to point out this non-obstructive population. So CT has the very unique ability to identify non-obstructive atherosclerosis, and these are at-risk patients. Now, they may not have ischemia on a non-invasive functional stress test, but they're at risk of developing downstream cardiovascular events. And we'll talk about this patient population a little bit more in detail later on in the talk about what we can do for them to perhaps minimize that risk. But these are still at-risk patients, and CT affords the unique ability to identify these patients over all other non-invasive functional stress tests. And we can look beyond the lumen, and we can characterize plaque. So if this patient underwent an invasive coronary angiogram, right, so the ICA is a luminogram. We're injecting dye into the coronaries, and we're assessing the lumen. But CT can go beyond that, and I know there may be some glare from the window here, but if you look carefully, there's this positive remodeled plaque right here in the prox LAD. Now that would be missed with an ICA, with an invasive coronary angiogram. But this is an adverse plaque characteristics that has been shown, and I'll present some data later, that has been associated with downstream acute coronary syndromes. Okay, so, and remember we were talking about how how CT is a 3D acquisition. You can perform these double oblique images and perform cross-sectional views of is there any way we can maybe shut this right here? You might be able to see it better. Yeah, so, yeah. So if you look carefully, so I feel like I'm Batman oftentimes in my office because my lights are always off looking at these images. This is way too much light for me. I'm not used to all this light. But so you can really appreciate the positive remodel, this crescent shape right here. This is all non-calcified plaque, which is what we call positive remodeled, that has been shown to be implicated with downstream events. So this is an at-risk patient, and this would have been missed on a straight luminogram with an invasive coronary angiogram. Now, CT positive remodeling has been correlated very nicely with intravascular ultrasound imaging. This is a study published by Stefan Achenbach and Jack in 2006. And here you can appreciate that outward remodeling on CT angiogram. And as I said, it's been correlated very nicely with intravascular imaging. This is a landmark study that was published in Jack in 2009, looking at these adverse plaque characteristics in trying to predict not ischemia, but downstream acute coronary syndrome. So plaques that are at risk to rupture and be culprit vessels. And they basically divided up, they assessed for two adverse plaque characteristics. One was positive remodeling, which is what we just talked about, that outward expansion of the plaque. And then they looked at the Hounsfield units to look at the plaque composition, and using a threshold of 30 Hounsfield units or less to suggest that there's large lipid-rich necrotic core that would predict downstream events. And if patients had both positive remodeling and low attenuated plaque, they had a 22% risk of developing a downstream acute coronary syndrome. So over 10,000 coronary segments were analyzed at 27 months follow-up. And what's interesting is that all the events, the acute coronary syndrome events, occurred in stenosis less than 75%. So there's a lot more to the story than stenosis severity. And plaque characteristics, composition, and we'll talk about the importance of the totality of the plaque burden or the aggregate plaque volume as well in trying to predict downstream events. So we can use these same adverse plaque characteristics in not only assessing acute coronary syndromes, but also in trying to predict ischemia, okay, which is a different question. Now, this is an example of an invasive coronary angiogram. At the time of QCA, it was noted that this LAD had a 36% diameter stenosis. Now, this is the same patient's CT image. And you can appreciate the large plaque burden. This white here is calcium. This grayish appearance is non-calcified plaque. And so this whole segment is caked with atherosclerosis, okay? And this is the same approx LAD lesion. Again, the outward expansion, the positive remodeling, the low Hounsfield units, okay? And this is another example of the positive remodeling here. This LAD, okay, although it was considered non-obstructive, less than 50% stenosis, was an ischemic vessel. And we'll talk about FFR later on in the talk, but the FFR, the fractional flow reserve, was 0.76, so below the 0.8 threshold that we typically use, in suggesting that this non-obstructive vessel was ischemic. Now, we can use the CT data in assessing the burden of disease. One metric we can use to quantify the burden of disease is the aggregate plaque volume, so the APV. And this is patient number 1 up here. This is patient number 2 down here. Patient number 1 had a diameter stenosis of 55%. Okay. Patient number 2 had a tighter lesion. It was 63%. In its stenosis severity, but the aggregate plaque volume was much lower. It was 27% compared to the ischemic lesion, which was 60%. So this patient's FFR, okay, an assessment of the ischemic potential of the lesion, was quite low, very low, markedly positive, despite having a smaller diameter stenosis, but larger plaque burden. So these plaque parameters, such as positive remodeling, low Hounsfield units, and the totality of the burden of disease, indicate both increased risk of cardiac events and ischemia. And it may be hard to appreciate here, but this is the left main, and then this whole area right here is atherosclerosis. From the distal left main all the way down the proximal LAD. If you did a cath, you may just say, oh, well, there's no focal obstruction, small caliber vessels. It's just a small caliber LAD. Well, in fact, this is large plaque burden, and in fact, this patient's LAD was highly functionally significant, ischemic, and this patient underwent a LEMA. So now I'd like to switch gears and talk about some data utilizing CT in the emergency department setting for acute chest pain. This was one of the first studies that was published in JACC in 2011 called CT STAT, comparing CT to traditional functional stress testing, specifically stress MPI. This is large healthcare burden, greater than $10 billion diagnostic costs annually. Greater than 8 to 9 million patients present to the emergency department every year with acute chest pain. And what they found was that compared to stress MPI, the time to diagnosis was significantly lower in the CTA arm compared to nuclear stress testing. So nearly half the time to diagnosis. And that also translated into a reduction in total emergency department costs. So a little bit over $2,000 for CTA and almost $3,500 for the stress MPI arm. And there was no change in major adverse cardiac events, so it was safe. And there have been other studies published in New England Journal of Medicine and others, such as Ramakat and Akron, PA, corroborating these findings, also pointing to the efficiency of CTA in not only reducing the time to diagnosis, but also the time to discharge. So here's an example of a 69-year-old male with hypertension who had an episode of chest pain at 1 p.m., didn't seek medical attention for a few hours, presented to the ED at 4 p.m., who at the time, when he presented to the ED, had no more chest pain. This was his initial EKG, so pretty unremarkable. 20 minutes after presentation, he went to the CT scanner, and he had this proximal LAD lesion right here. 20 minutes after that, he was rushed to the cath lab, corroborated the CT finding, and underwent successful PCI of that prox LAD lesion. Now, this goes back to the importance and the major value of CT in the identification of non-obstructive coronary artery disease. So this study, published in 2015 in atherosclerosis, studied over 8,000 patients who were all found to have non-obstructive disease, so less than 50% stenosis. And they compared those that were on statins versus those that were not on statins. And what they found was that there was a statistically significant reduction in both overall mortality as well as downstream revascularization, whether it be with percutaneous coronary intervention or bypass surgery in those that were on statins. And that was irrespective of the underlying clinical risk factors. So the unique opportunity to intervene on these patients with non-obstructive disease and reducing their downstream events. Again, no other functional non-invasive stress test can identify those patients. And what they did was then they looked at subgroups. Whether you were young or old, less than 65 or greater than 65, whether you're male or female, whether you're diabetic or not. I wanted to point out this subgroup. Even in those with baseline LDLs less than 100, if you were started on a statin, you had a significantly reduced risk of developing downstream PCI, bypass, and your survival was better. Okay, again, underscoring that there's more to the story than cholesterol in identifying these patients at risk, and the benefits of statins, the pleiotropic benefits of statins beyond lipid lowering. So the anti-inflammatory effects, the plaque stabilization effects, perhaps the improvement in endothelial function with statins. So if in my practice, if I perform a CT on one of my patients, irrespective of whether their LDL is 70 or 80 or 120, even if I don't have a lipid profile, I'm starting a statin on that patient. So this was data published in Lancet, subsequently published in JACC, and I'll present the 5-year data that was just published in New England Journal of Medicine a few months ago from Scott Hart. It was a randomized controlled trial of over 4,000 patients, divided up into standard of care versus standard of care plus CT coronary angiography. It was an intention to treat analysis. These are all patients who were referred for suspected angina due to coronary heart disease. 12 centers across Scotland, and there were no restrictions according to whether they had baseline arrhythmia, which can sometimes be problematic in coronary CTA because you need to gate to RR intervals and you need to make sure to try to minimize cardiac motion. So they had no restrictions in coronary arrhythmia. They were scanning patients with BMIs of 65, so very, very high risk, like low, patients that can degrade image quality significantly, and calcium scores of up to 9,000. So these were higher risk CT scans, but despite that, they were able to demonstrate pretty remarkable findings that I'll present. And the mean radiation dose was about 4.1 millisieverts. Any idea of what we all get annually by living on Earth on a yearly basis?
2 or 3 millisieverts.
Exactly. So it's about 3 millisieverts, 2 to 3 millisieverts. All of us get, on an annual basis. So not much higher than that. Median radiation dose was 4.1 millisieverts. And in fact, 37% of the radiation dose was attributed to the calcium score. And you could argue if these patients are symptomatic with suspected coronary artery disease, do you even need to do the calcium score? Can you go straight to the CTA, especially if you're doing CTAs on patients with CAC scores up to 9,000? So you could have even reduced that number by 37%. So these are some of the findings. What they were able to demonstrate is that there was an overall change in the treatment strategy in the CTA arm compared to the standard of care arm at a much higher degree. So there was a safe cancellation of all therapies, anti-anginals, and preventative therapeutics in the CTA arm. So you can de-escalate therapy, if you will. So let's say you do the CT, and we talked about the negative predictive value of a normal CTA scan. So the providers would stop perhaps some of these medications, and the contrary is true. If they identified atherosclerosis, they were more likely to start preventative therapeutics and start anti-anginal therapies compared to standard of care. And what they found was a reduction in overall coronary heart disease death and non-fatal MI, so hard clinical endpoints in the CTA arm compared to standard of care. This was the original Lancet data published in 2015. And if you look at the composite endpoint of coronary heart disease death, non-fatal MI, non-fatal stroke, there was also a reduction in events in the CTA arm. Now, as I said, the 5-year data was just presented in New England Journal of Medicine in September of 2018, noting a significant reduction in myocardial infarction from the Scott Hart trial using a CT-guided strategy compared to standard of care functional stress test. So we're using a diagnostic test where it's providing actionable data, we're intervening, and that's translating into a reduction in hard clinical endpoints. It's hard to show that with non-invasive tests these days, but we have strong data now using coronary CTA. Now, as everyone in this room is well aware, there are various treatment strategies for coronary artery disease, and I tell all the fellows, med students, and residents that we train that meds work for many patients. And when you have stable ischemic heart disease, our anti-anginal regimens are fantastic. Statins are great drugs. They save lives. So for many patients, optimal medical therapy is all they need. But for some, they need revascularization. So they need PCI, they need bypass. And for PCI, a focal narrowing and ischemia are both needed to warrant intervention. So that brings us to FFR. So we've seen a major paradigm shift over the last decade or two away from a revascularization strategy guided by anatomic stenosis, the so-called oculostenotic reflex, to one that bridges both the anatomy and the physiology, in guiding revascularization. So one technique that we can use in the cath lab, traditionally, has been called FFR, It's called FFR, fractional flow reserve, where we perform the invasive coronary angiogram, we identify an intermediate lesion, we then thread a pressure wire distal to that lesion, we induce maximal hyperemia, we assess the pressure distal to that lesion, we compare it to the central aortic pressure. And if that ratio is less than 0.8 or 0.75, depending on the literature you're reading, then that would suggest that that specific lesion is ischemic and it should be revascularized. And we learned this from the New England Journal of Medicine papers from FAME 1 and FAME 2. FAME 1 taught us that we can safely defer percutaneous intervention with lesions that have FFRs greater than 0.8. Okay, so a less than 20% drop in pressure essentially. And then from FAME2, in multivessel disease, we should be performing percutaneous intervention of lesions with FFRs less than 0.8. So the current diagnosis and management of CAD requires an understanding of two fundamental questions. One, is there stenosis? Is there an epicardial narrowing? And we've talked about how CT is a fantastic alternative now to invasive coronary angiography in identifying anatomic stenosis. And then we have to assess for ischemia, and traditionally we've done that with functional stress tests, so stress echo, stress ECG, SPECT. So you can see that oftentimes the patient has to undergo multiple layers of tests to get to the bottom of these fundamental questions. And we just talked about how FFR, or fractional flow reserve, has emerged as the gold standard bridge test to determine optimal medical versus percutaneous intervention artery-specific therapy. Now, using fractional flow reserve to guide therapy has resulted in a 33% reduction in the risk of death or major adverse cardiac events, and has translated into a reduction in overall healthcare costs. Now, this is an important slide, underscoring the discordance between anatomic stenosis and functional relevance of a specific lesion. And in fact, the majority of lesions who have a 50 to 70% diameter reduction are incorrectly identified for stent placement based off of angiography alone. Okay, so what you can see here is that in these patients with a 50 to 70% stenosis, 2/3 of them had a negative invasive FFR and could have been safely deferred from percutaneous intervention. Okay? Even if you look at the subgroup of patients with severe stenosis, we're talking 71 to 90% diameter reduction, severe stenosis. 1/5 of them, so 20%, had a negative invasive FFR and could have safely deferred a percutaneous intervention and could have been treated medically. Now, let's focus on the quote-unquote non-obstructive lesions. Data from the Ripcord study would suggest that 33% of lesions graded 31 to 50% diameter reduction indeed had FFR values less than 0.8. Now the question still remains, what do you do for these patients, right? Do you revascularize these patients? We don't really have data to support that right now, but it's just intriguing and underscores, again, the discordance between anatomy and physiology, that you can still have a non-obstructive stenosis that causes ischemia, and it's still debatable what to do for those patients. Now, current non-invasive tests do not measure lesion-specific ischemia and don't compare well to invasive FFR. Now, the reference standard is invasive FFR, not anatomic stenosis. So stress echo and nuclear SPECT imaging has quite poor sensitivity. Now, CTA is not perfect either. Although the sensitivity is very high, we don't miss disease with CTA alone. The specificity is quite low, so the positive predictive value is also quite low when comparing CTA to invasive FFR as a reference standard. So ideally, you'd have a test that's non-invasive that has the sensitivity of CTA with a higher specificity in diagnosing lesion-specific ischemia. And now FFR can be derived from a static standard coronary CT angiogram. It's FDA approved. This is an example of a three-dimensional FFR CT map that can be computed. You can interact with this model. There's an app that I have on my phone, and I pull it up and discuss it with my patients when they're in clinic with me. You can pan, zoom. You can identify any particular segment and region of interest and get a representative FFR value along the coronary tree. Shades of blue are all normal blood flow. Shades of red would suggest ischemic territories. Okay, and FFR CT is derived from a standard, typical coronary CT angiogram. There's no additional radiation to the patient. There's no change in the imaging protocol, and there's no additional medications that need to be administered to the patient. So it's all derived from the raw data of a static coronary CT angiogram. Thus far, there have been 3 prospective multi-center trials looking at the diagnostic performance of non-invasive FFR CT compared to invasive FFR as a reference standard, published in high-impact journals such as JACC, JAMA, and the most recent NXT trial published in the Journal of American College of Cardiology as well. The NXT trial was completed in 2013, 10 worldwide sites, and they reported a per patient sensitivity and specificity of 84 and 86% respectively. So you can see from the NXT trial, the specificity, which is a problem in CTA, was markedly improved with FFRCT. So FFRCT reclassified 68% of CT false positives as true negatives. Now, I'd like to go back to these two cases just to see if people were paying attention or listening. Which one of these vessels is ischemic? Is it this one or is it this one? The one on the left, exactly. So despite the one on the left having a QCA of only 36%, okay, this patient had a large aggregate plaque volume with evidence of adverse plaque characteristics that we talked about earlier, and this was an ischemic vessel as compared to this, which had a much tighter stenosis that had an FFR that was negative. So more to the story than stenosis. Now, when looking at the diagnostic performance of coronary diagnostic tests compared to invasive FFR as a reference standard, where you want to lie on this slide is in the top right? You want a test that has high specificity and a test that has high sensitivity. Okay, and you can see that with the most recent NXT trial published in Journal of American College of Cardiology, that FFRCT had higher sensitivity and specificity compared to other non-invasive tests. Here are two case examples. Patient number 1 up top had a greater than 50% diameter stenosis in the LAD, had an FFRCT that suggested an ischemic vessel. The invasive coronary angiogram confirmed the CT finding, and the invasive FFR corroborated the FFRCT. So both the invasive and non-invasive FFR values are 0.74. Here's patient number 2 with a circ lesion here, greater than 50% diameter stenosis. The FFRCT was negative, so 0.85 above the 0.8 threshold. And the invasive angiogram corroborated the CT, and again, the invasive FFR suggesting no ischemia in that circumflex. This patient could be treated medically. Now we have some, this is data from the platform study, which was a clinical utility trial comparing 2 distinct management strategies, basically usual care compared to an FFRCT guided strategy. And what the platform investigators were able to demonstrate is a dramatic reduction in cath with no obstructive disease. And if you recall from that New England Journal of Medicine paper that I presented, one of the earliest slides, saying how this is a major problem in the US, how many of our patients are getting cathed to only tell them they don't have obstructive coronary disease. So the platform investigators were able to demonstrate that using FFRCT, there was a dramatic reduction in caths showing no obstructive coronary disease. It went from 73% to 12% using FFRCT. And equally important is the fact that 61% of caths were canceled. And you may say, well, is this safe? We're not cathing 61% of the patients that we would have otherwise done with usual care. And the answer to that question is yes. There was proven safety and durability, durable results through 1 year, and this is data published by presented by Pam Douglas out of Duke University and at the American College of Cardiology in 2016. Of the 61% of patients whose caths were canceled, there were no adverse clinical events in any of those 117 patients using FFRCT. And you can imagine that when you're safely deferring invasive coronary angiography, that's translating into a reduction in healthcare costs. And that's what they were able to demonstrate as well. There was a cost savings of 26% to the healthcare system. And this was even after accounting for the cost of the FFRCT analysis. This is some of our own data that I presented at the American Heart Association that same year. 138 patients with suspected CAD who were referred for coronary CTA and FFRCT for evaluation of symptoms. Now, not all patients need FFRCT, okay? If the CT is negative, then there's no real value in getting the FFRCT. It's really in those intermediate lesions So it's really a CTA plus or minus FFRCT guided strategy. If the CTA is clean, we talked about the negative predictive value, we talked about the warranty period, you don't really need the FFRCT, but it's only in those intermediate lesions. So 57% or 57 patients had intermediate stenosis that required evaluation with FFRCT, and you can see the reduction in invasive coronary angiograms. And there were no adverse events in any of the patients whose caths were canceled. And this next stat should resonate with a lot of the interventionalists in the audience here. Cath lab resources were used efficiently. And what I mean by that is the majority of the patients that were studying the cath lab are getting appropriate revascularization, right? So in this particular presentation, 9 of 12, so 75% underwent revascularization at the time of the cath. This is some data that I presented at the American College of Cardiology in 2017, looking at cost analysis. Now over 200 patients with a suspected CAD and CT plus FFRCT if needed. And again, no adverse events were reported in any of the patients whose caths were canceled. And with the CT alone guided strategy, you can see the high cost of invasive coronary angiography here, roughly $258,000. Now, after incorporating FFRCT, that invasive coronary angiogram cost goes down significantly to around $96,000. And even after accounting for the cost of FFRCT, which is in the salmon color here, of $118,000, the overall cost of care for this population was reduced by 14% when incorporating FFRCT, and the per patient costs were also lower with FFRCT, a little bit over $1,300 compared to a little bit over $1,500. And these are all costs based off of Medicare reimbursement rates. This is some data that we presented at the Society of Cardiovascular CT, looking at a specific subset of patients with prior equivocal stress tests. This is a very common clinical dilemma, at least in my practice, and I think in many practices. Patients that come to you into your office with a functional stress test, and their EKG is positive, their imaging is negative, or vice versa. Their imaging is positive, their EKG is negative. And they have some symptoms. They're like, doc, they want an answer. You know, is this positive? Is this negative? Honestly, I struggle with these patients. I don't know what to tell them because we don't really know. So what we did was we employed a CT plus CT FFRCT strategy in these patients with prior equivocal stress tests. And what we were able to demonstrate is that with CT alone, 45% would have undergone invasive coronary angiography after their CT scan. And then after incorporating FFRCT, that number was reduced to 14%. So again, a safe reduction in downstream cath, and 80% of angiograms led to revascularization. Again, the high efficiency in the cath lab. So we're sending the patients who need to get revascularized. This is one of the cases from the paper that we published in JCCT 2017 on how to interpret the FFRCT analysis in clinical practice. And I would encourage anyone that has interest in this technology to take a look at this paper. It has really nice, maybe 4 or 5 really nice case examples, and some background on the technology, a little bit of the science. And this is one of the cases that are presented. There's a prox LAD lesion here. Again, 50 to 70% diameter reduction. Highly ischemic LAD. A lot of red here. Values of 0.68 distal to this lesion. The invasive angiogram corroborating the CT finding, and this is the post-PCI outcome of the patient, and they're doing well at follow-up. This is one of my patients that I've been following for over 3 years now. Prox LAD lesion here. Again, around 50 to 70% diameter reduction here. The FFRCT was negative throughout the LAD. This patient was safely deferred an invasive angiogram, and as I said, I've been seeing her for over 3 years now, and she's doing just fine on medical therapy. So safe cancellation of downstream cath. So these are some future applications of the technology that we presented in JAC imaging a few years ago, using computational fluid dynamics to look at various other metrics. Looking at one day we'll be able to hopefully assess percent myocardial blood flow at risk, similar to what we do with nuclear stress tests to assess 5% myocardium at risk, 10%, some stress scores, all of that. Perhaps one day we'll be able to use FFRCT to assess percent myocardial blood flow. from the CT scan, we can assess this new metric called volume to mass that I'll touch on one or two slides later on. Basically looking at supply-demand mismatch in an individual patient's coronaries, which may shed light into the ischemic potential of non-obstructive lesions. And then we'll talk about that in a little bit. And then akin to the invasive arena, one day we'll be able to, well, actually we now can perform functional syntax score. The Revolution study was just presented and published by Professor Sorois in JACC, looking at high-risk CT, so multivessel disease, left main disease patients, and showing and demonstrating that we can assess functional syntax scores non-invasively as well. And then using some novel metrics, using computational fluid dynamic algorithms to assess for forces and plaque stresses across lesions, looking at delta changes of pressure differentials across lesions to shed light onto the vulnerability of specific lesions as well. So angiographically normal coronaries may have low measured FFR and measured and computed FFR values. So if you look at this LAD lesion or LAD vessel here, there isn't a focal narrowing. You may call this a normal LAD, but when the investigators thread a pressure wire in that distal LAD, the FFR value was 0.73, and the corresponding FFR CT also demonstrated an ischemic vessel here. So, quote unquote, normal coronary angiogram may not necessarily be normal, and the question is why? Okay, the question is why. And perhaps this volume to mass metric may add value and shed light into why that LAD was indeed ischemic. So we know that coronary artery flow scales with both vascular volume and the mass, and both can be derived from that CT scan. Okay, so the ratio of the vascular volume to myocardial mass may provide insight into ischemia related to the inadequate coronary supply to a given myocardial tissue demand. So it's essentially a supply-demand mismatch. And if you go back to the case that I just presented, okay, the volume to mass ratio was low. Okay, and there have been various reference thresholds as far as what's normal, what's not normal. Some investigators are using 30 or 31 as a cutoff for low VM. So this patient's VM was 21, and that may, again, play a role into the ischemic potential of this particular vessel. Now, this is some data published in JACC Interventions looking at what we call virtual stenting, where one of the other future applications is to then perform pre-procedural planning, where we identify the lesion, we perform the FFR CT, we are able to say, okay, this needs further attention, needs revascularization. Let's put in a 2.5 by 30 millimeter stent and assess for the downstream outcome of that patient. So not only will we be able to use CT as a gatekeeper, if you will, to the cath lab, but also to guide appropriate revascularization strategies. This was 44 patients that they assessed, and the overall diagnostic accuracy was 96%. This is before stenting, an ischemic LAD lesion, okay, and that was corroborated on invasive FFR. And then this was the virtual stent that after you place this stent right here, the FFR CT would be 0.86, and this is post-PCI, and the FFR went up to 0.9. So again, using the same computational fluid dynamic algorithms to predict therapeutic benefit of revascularization. So this is some really exciting data from the Emerald study that was presented at EuroPCR. In looking at some of these computational fluid dynamic metrics beyond FFR values, but looking at wall shear stresses, axial plaque stresses, pressures across lesions, and delta gradients across the lesion, in not predicting ischemia, okay, but predicting acute coronary syndromes. And what the investigators were able to demonstrate is that culprit vessels had lower nadir FFR CT values, higher delta FFR CT gradients, higher delta pressure gradients across the lesions, higher wall shear stresses, and axial plaque stresses. And if you look at the C index, incorporating percent diameter stenosis adverse plaque characteristics and these adverse hemodynamic forces, the model incorporating all of these variables had the highest statistically significant C index of 0.7, almost 7, in predicting downstream acute coronary syndromes. And perhaps one day we'll be able to create this integrated CTA risk score, incorporating parameters such as diameter stenosis, adverse plaque characteristics, higher delta FFR gradients, high adverse plaque or axial plaque stresses. And if you have all of these parameters, then you have a high risk of developing a downstream acute coronary syndrome. And that brings us to the recent NICE guidelines from the UK, the National Institute of Health and Care Excellence, that in 2016 performed a rigorous evidence-based evaluation of the totality of the data, looking at all the non-invasive stress tests out there, CTA, and made a bold statement saying that in patients with new onset chest pain, CT should be the first-line diagnostic strategy for chest pain evaluation. And we should then offer non-invasive functional imaging, including FFRCT, for myocardial ischemia when the CT has shown coronary disease of uncertain significance. Okay, so a big statement by the NICE guidelines in the UK in 2016. And I suspect in the US over the ensuing few years, we're going to see more widespread adoption of CT angiography as a first-line diagnostic strategy. So in conclusion, CTA offers excellent diagnostic accuracy as well as prognostication. It's safe and can be utilized as an acceptable alternative to functional stress testing. CTA findings guide therapeutic decision-making that confers clinical benefit. And FFRCT sheds light on which lesions as well as patients will benefit from revascularization beyond stenosis. And we've demonstrated that FFRCT can safely avoid unnecessary invasive angiograms. And the data from Emerald is suggesting that these adverse hemodynamic characteristics from CTs are actually better discriminators of culprit lesions that cause acute coronary syndrome than stenosis severity or even adverse plaque characteristics alone. So I think what we're going to see in the US with more widespread adoption with FFRCT is a major transformation in the cath lab. I think what we're going to see is a major reduction in diagnostic caths, and the cath lab is going to be transformed into an interventional suite, whereby we're sending the appropriate patients to go to the cath lab to get revascularized and not just take a look. And I feel like that's the way it should be. So I'm going to end there, and I'm happy to take any questions if you have any. Thank you.
So Mark, can you talk briefly just about the nuts and bolts of how these tests are done in terms of how much contrast, how long does it take, beta blocker use, how long does it take to actually do the post-processing to get the high-quality images that you have shown here today?
Yeah, so that's a great question. So it's all about image quality, so I'm glad you brought this up. Because, if you have poor image quality from the CT scan, we won't be able to perform high-quality FFRCT analysis. So image quality is key. And it starts with really beta blockade, especially, it depends on the scanner you're utilizing, okay? Perhaps with dual source scanners with higher temporal resolution, you can get away with slightly higher heart rates. But, for example, in many centers, it still is really important to get the patients beta blocked. And we have a dedicated cardiac imaging fellow at our institution that is instrumental and we have protocols in place. We have protocols in place that the nurses, once the patient presents, to the holding area, there's a protocol that we use, and we administer. We use a lot of metoprolol tartrate. We start with 100 of metoprolol tartrate if their heart rate is above 65. We really are aggressive with getting their heart rates down, because the slower you get the heart rate, the better image quality. So that's really key. You also don't want to be scanning everyone with a BMI of 40 and above, because that can degrade image quality as well. Obviously, it's hard to work around that. But really getting the heart rate down is key. And so whether you have an APN, an advanced fellow, a resident, somebody that can get the heart rates down is key. Then it's really important to give the patient nitroglycerin, the sublingual nitro, or the spray. Usually we administer that 5 minutes before the CT scan. And then once the CT is acquired, we have, a schedule in place where there's a dedicated cardiologist that is reading the cardiac portion of the scan, and then, the non-cardiac portion goes to the radiologist. We'll interpret the CT the same day of the acquisition. And then at that point, because we don't really know if they need the FFR CT till we take a look at the CT scan. So at the same day of the acquisition, we'll interpret the CT, and if there's an intermediate lesion, then we'll send it for FFR CT analysis at that point. And then it usually they've really come a long way as far as turnaround time. When we started, it was much longer, but now it's like a few hours in getting the FFR CT analysis back. And then there are various ways to interpret it. Some, at our center, we create one report. So we'll pend the coronary CTA. We'll wait and if we need the FFR CT, if we don't need it, then we'll just sign it. If we need the FFR CT, we'll wait for it to come back. The fellow usually dictates it, and then they'll send it to our queue, pend it. Once we get the FFR CT back, then we'll just add that into the body of the text with one interpretation. But some centers addend it, so they'll sign the CT, and then they'll wait for the FFR CT to come back, and then they'll just addend the CTA report. But I just think it's cleaner, and it's easier to interpret when we do one interpretation for the provider, referring physician.
And how much contrast do you normally give them now for a CTA?
Yeah, so contrast about 70 cc's, I would say. And depending on the scanner that you utilize, depending on the type of gating you utilize, whether you perform prospective or retrospective scanning, oftentimes now many centers are doing prospective gating with perhaps some padding. I mean, we're talking millisieverts less than 5, consistently. So yeah, 70 cc's of contrast, I'd say around 5 millisieverts of radiation.
And the time it takes for you to process and look at the images and generate a report?
So if it's good image quality and the CT's negative, it's pretty fast. Now it gets a little bit more laborious if you have extensive diffuse atherosclerosis. That takes time. It takes time because you have to segment, the epicardial coronaries, and so it depends on the complexity of the atherosclerosis. But in the setting of a negative CT, I don't know, 15 minutes, 10 minutes, 10 minutes. It could go up. If you have significant atherosclerotic burden, it can go up.
And then how about calcium in terms of ability to interpret the severity of the stenosis in the setting of moderate to severe or diffuse calcium?
Yeah, so that's a great question. Yeah, you've got great questions. Yeah, so the calcium is problematic. It is an Achilles heel of CT. And multiple studies would suggest that we overestimate stenosis with the calcium because there are these artifacts called blooming artifacts that can occur with calcium in the setting of a CT scan that can make stenosis look worse than it actually is. So it can be problematic. Now, I know that, and in fact, HeartFlow actually has put a lot of R&D into trying to enhance the interpretation of lesions with significant calcific burden, specifically looking at CT calcium versus OCT, intravascular imaging using OCT, and trying to, refine that interpretation. But it still is problematic for me in my practice when I'm interpreting CTs, especially if it's dense calcium through and through. Oftentimes calcium can be eccentric, and then you can work around it, and you can window and level things and try to see the lumen. But yeah, if it's through and through calcium, dense calcium, then it can be challenging.
And does that calcium impact the FFR diagnostic capability?
So I actually had a slide on that, but I didn't want to go over. There was a sub-analysis from the NXT trial, that diagnostic performance study published in JACC, looking at that specific question. And the diagnostic performance was not degraded. It was the same. And and they divided up these patients into quartiles of calcium. And even in those with the highest, calcific burden, the performance was the same. Yeah. But for my interpretation, for the CT alone, it can be problematic. Yeah. Yeah.
Has your institution integrated this into your emergency room chest protocol?
So not yet, not yet. There's been talk about that. We also have like an observation unit at our institution, and we're thinking about perhaps implementing it in the OBS unit as well. There are some centers in the U.S. that are utilizing CT in the ER setting, and there's strong data for that as well. I think I presented the CT stat trial, and there's the RamaCAD and Akron PA. And in fact, there's a center that I'm aware of in the U.S. that is now utilizing FFR CT, not just CT alone, but FFR CT in the acute chest pain setting. And hopefully we'll have some data published about their outcomes, which seems pretty compelling actually in the next few months. So yes, there are centers utilizing it. We're not yet. There are a lot of logistics behind it. You need to have the manpower. When are you going to offer it 24/7? Who's going to interpret it? But
This is sort of something you guys do during business hours, Monday through Friday, for stable-ish outpatients at this point?
Yeah, so the majority of our patient population are stable ischemic heart disease elective outpatients, exactly. Now, it depends on the cardiologist who's rounding in the hospital. We have like 4 or 5 different cardiologists rounding the hospital, like heart failure, consults, inpatient. So let's say the inpatient cardiologist has a patient that they want to order a CT on, we'll do it, but the majority are outpatient elective cases. And then there are ways where we can expedite the turnaround time if FFR CT is needed in the inpatient setting, and then they usually have a turnaround time within an hour or two. So it's pretty fast. Yeah.
Additional questions?
In your talk, you said numerous times that many centers, if you had to predict, when would you say this would be adopted as a standard of care for cardiac prediction?
Yeah, so I think in the U.S., I think that we're going to see some dramatic changes with guidelines in the next year or two. There's a lot of buzz about CT now as a first-line diagnostic strategy. I think we have really strong data. I mean, the 5-year outcome data from Scott Heart showing a reduction in heart outcomes using an imaging strategy, right? It's hard to show. We can scan every patient in this room right now, but it's not the image that's going to improve outcomes. It's what are we going to do with the data that's going to then translate into reduction in events? And we're showing that with CT. So I think that data is very strong. And I think over the next few years, we're going to see a transition away from functional stress tests into a more anatomic assessment, which is what we're seeing in the UK. That's why I presented them the NICE guidelines. And they performed a rigorous evaluation of the totality of the evidence. I mean, we're seeing, Japan has been using CT for many years, and all of Europe actually has adopted CT more so than us in the US. And there are multiple layers to that, but I think the data is going to speak for itself. And I think over the next few years, we're going to see a major transition. I think it's best for patients, and I think it's best for the healthcare system. And if I don't want to undergo a cath unless I need it, right? So if I was sitting in that chair, I'd want to know that I need that cath to get revascularized. I think that's the way it should be.
Well, I neglected to do this up front, but I wanted to thank Doug Crowhurst from HeartFlow for sponsoring this morning's talk. HeartFlow is the company that's developed this CT-FFR technology, and this was a fantastic lecture. So, Mark, thanks to you also for really a great overview.
Oh, of course. It's my pleasure.
Hope to have you back sometime.
Yeah, and feel free to reach out anytime if you have any questions on adopting the technology.
Waiting on Mark's dance.